Thank you very much for this kind invitation. I'm going to talk about standard treatments for advanced prostate cancer and give a global perspective. My disclosures are shown here, the only two that are relevant, first and the last ones. And most of this presentation is taken from a chapter recently completed by Dr. David Einstein and myself as part of the ASCO self-evaluation program on genitourinary cancers, which is available for anyone that would like a copy of that chapter. In my 12 minutes, I'm going to talk about the nomenclature for advanced prostate cancer, the evolution of new states of prostate cancer. We'll overview the standard treatments for advanced and metastatic disease, not focusing at all on precision or genomic influences of treatment decisions, and then a comment on global inequities of prostate cancer care throughout the world. There's a changing nomenclature for advanced prostate cancer. In the past, we would call patients with localized or regionally advanced disease, which we still consider. Biochemical relapse can now be considered a patient with biochemical relapse, or also be considered to have non-metastatic castration-sensitive prostate cancer. Those patients, if treated with hormonal therapy, as I'll mention momentarily, will develop non-metastatic castration-resistant prostate cancer, for which there are now 3 drugs approved, which we'll mention briefly. Metastatic disease in the past used to be classified as either low or high volume. We can now call those patients as having castration-sensitive metastatic prostate cancer prior to chemotherapy, and both assign the volume of tumor burden in those patients. In the past, we considered patients to have hormonally refractory metastatic prostate cancer, metastatic castration-resistant prostate cancer, which we still consider. Most patients can be considered to be pre or post-chemotherapy. And then patients with 3 to 5 metastases are now considered sort of a novel form of stage 4 disease that we will consider to be oligometastatic disease, which will be covered by other experts in this panel discussion. Just a comment about the development of non-metastatic prostate cancer. So in the past, patients would have primary curative therapy. If they ended up developing a PSA recurrent disease, not much would be done for those patients until they developed metastases. Then they would get delayed androgen deprivation therapy in the setting of metastatic disease. And over a period of time, those patients would evolve into metastatic castration-resistant disease. This slide, which was put together by the FDA when they were trying to determine endpoints for approval of products in the non-metastatic setting, indicated that here we have the introduction of early ADT in patients with an elevation in their PSA value, and those patients would end up eventually having the development of non-metastatic castration-resistant disease, which is really a iatrogenic disease by virtue of the introduction of early ADT. And now drugs can be approved on lengthening the time for metastasis-free survival. And those patients who end up developing metastases would eventually develop metastatic castration-resistant prostate cancer. So again, this is sort of the evolution of this new classification of disease that we call non-metastatic castration-resistant disease. And the studies supporting the use of either darolutamide, enzalutamide, or apalutamide in this setting is shown here. Basically, the Aramis, the Prosper, and the Spartan study all showed an improved metastasis-free survival with the administration of one of these 3 agents to improving the overall metastasis-free data. Again, overall survival is sort of emerging from these. We think that MFS may actually be a surrogate for overall survival in these patient populations. Those studies are ongoing. The systemic treatments for metastatic castration-sensitive prostate cancer is shown here. Whether you've had prior local therapy or present de novo, here are the sort of the stratifications of how we consider treatment for metastatic castration-sensitive prostate cancer. If the patient typically would use a GnRH agonist or an antagonist, plus or minus bicalutamide, and consider single-agent bicalutamide if the patient was too frail to receive other systemic therapies. Based upon the charted data, if the patient had high-volume disease, the patient would be considered for ADT plus 6 cycles of docetaxel. And obviously, the new data suggests that support for ADT plus either abiraterone, prednisone, ADT plus apalutamide, or ADT plus enzalutamide And over a period of time, those patients can continue on those therapies after the completion of docetaxel. And over a period of time, those patients may end up developing metastatic castration-resistant prostate cancer at the time of progression. And one should always remember to consider prostate radiation therapy for low-volume disease and also determine appropriate field sizes if the pelvic nodes are involved. On the left, we show the types of populations of patients that have been treated in the metastatic castration-sensitive prostate cancer. And this is a slide that was put together by my colleague, Dr. Einstein, as part of the SCP chapter for ASCO. For the development of metastatic castration-resistant prostate cancer, we now come to this slide, in which patients who have had previous therapy can be considered for. Those patients that have had ADT plus abiraterone can be considered for the administration of enzalutamide, or vice versa. If they had had either docetaxel or abiraterone prior, to be considered for enzalutamide under those circumstances. The use of ARV7 can sometimes help inform decisions because ARV7 testing prior to initiating second-line androgen signaling inhibitors can be considered for the use of docetaxel in lieu of second-line ASIs for patients in whom the ARV7 is detected. And then docetaxel and cabazitaxel can be included either as first-line or second-line therapy of the cabazitaxel in those patients that have become refractory to docetaxel. Now, obviously, what you're going to be hearing from the other experts in this session is the utility of biopsy for next-generation sequencing, looking for DDR alterations or MSI alterations that would inform the utility of a PARP inhibitor or PD-L1 or PD-1 inhibitors. Bone considerations in metastatic castration-resistant prostate cancer are shown here. For bone-predominant disease, radium-223 can be utilized at any point. For bone metastases in the castration-resistant population, the addition of bisphosphonate or denosumab throughout anti-cancer treatment is generally recommended. And finally, I'd like to end on the data supporting bone health and bone treatment options. Here's the Alsimka study that looked at the use of radium-223 as a treatment modality for bone-predominant to bone-only castration-resistant disease. Again, improvement in overall survival and also improved bone pain. For the use of bone health agents in the castration-resistant population in patients that have had no prior bisphosphonates, denosumab plus placebo versus Zometa plus placebo improve the time to first skeletal-related events in that patient population. And the final comment I want to make relates to the global perspective in mortality disparities for GU cancers. This is a portion of the chapter that Cora Sternberg and her colleagues contributed to. If we take a look at the overall global incidence of prostate cancer, 1.276 million patients, globally 360,000 deaths. We have what's considered to be a mortality to incidence ratio overall for this global population of 0.28. But when one looks at the mortality to incidence ratio in high income countries, it falls to 0.19, and mortality to incidence ratio in low middle income countries is a increase of 0.42, basically indicating an assessment of the health system performance for cancer care, and definitely disparities between those countries that have a higher per capita income compared to those patients that have a lower per capita income. So again, this is my 12-minute talk on standard therapies for advanced or metastatic prostate cancer, short of precision oncology, and just a snapshot into issues that we have to address on a more global basis relating to equity in cancer care and cancer outcomes, especially in prostate cancer, as you see from these data. Thank you very much for your attention.